let's talk about medications, okay? Mostly, what we're interested in for transport, most of the medications that we administer are having to do with the fact that either we want to assist the patient, either because we want them to be safe, and so we don't want them agitated, all right, or upset, all right, which means that we want to give them some sedation meds, all right, or we are concerned because of the type of perhaps injury they had, or whatever pathophysiologic process that they are experiencing could be painful, or perhaps an intervention or something that we or someone else have done could be painful, all right? So we like to give pain meds. And then if we are either attaining an airway or maintaining the airway for the patient, we would choose to paralyze them if it is appropriate to do so, okay? So we're going to talk about pain meds, sedatives, and paralytics, all right? You use these medications each and every day, perhaps this multiple meds on the same patient. You use these medications quite frequently. So yes, you are expected to know this information, okay? Do you have to have all the information that we're going to talk about today memorized all the time? Well, no, but you are certainly responsible for the significant points of discussion, and it would be preferred that the most significant, all right, you do know by memory. However, on a day-to-day basis, once again, this type of information lends itself very well to a cheat card, all right? When I was a second-year resident, now responsible for patients for which I had to administer these types of meds, I did not know them like the back of my hand. And so what I did was I made myself a cheat card so that I would remember the salient points, and in an emergency situation, I would not have to worry so much about if I remembered correctly either the dose or a side effect or how I was going to choose which medication and which to avoid, all right? So, a strong suggestion there. Okay, let's talk about pain meds and pain management. Typically, the meds we use, and remember I can't spell, are acetaminophen. Okay, I know we don't really think about that so much as a pain medication, but it is, and it's actually quite effective. Okay, so if you have someone, say, with a broken femur, you know, who's obviously going to take, you know, several or continual analgesic doses, okay? Even if they're NPO, you can give it rectally, all right? But don't forget about, you know, things like Tylenol or Motrin, okay? Because they can be quite effective, and they, if nothing else, they can at least kind of maintain some semblance of control for a couple of hours and be an adjunct to your narcotics, which is what we usually use, all right? So when we think about narcotics, we're really talking about morphine and fentanyl. Demerol is obviously a narcotic. There's nothing wrong with Demerol. It's just not usually the drug of choice. It's usually not the first line med. Oftentimes we choose Demerol. Certain patients, just like everything else, some people respond better to some drugs than others. I know that for some sickler patients, you can give them a whopping dose of morphine. It may put them to sleep for a few minutes, all right, but when they wake up, they express the fact that they are still in significant pain. Whereas if you give them Demerol, they usually tell you that that works a little more effectively. And again, that's patient by patient. sometimes we call Demerol a dirty drug because it does have many different metabolites, and that's why it's not the first line. Again, there's nothing wrong with it. It doesn't cause severe, problems, but for those assembly, reasons, we just don't use it firsthand. All right. When we're talking sedation, basically, we're talking benzos. Okay. We're talking about benzodiazepines. It's not the only thing we use, but it's certainly the most frequent. All right. And of those two, we usually use Versed and Ativan. Valium, again, sister drug of Ativan. Valium's kind of like Demerol. There's nothing really wrong with it, all right? It's just that the Ativan and Versed have properties that are usually more to our liking. They're cleaner drugs, and so they become our preferred agents, all right? Chloral hydrate is also a sedative, okay? It's classified as a sedative hypnotic. The advantage to chloral is that you usually do not get respiratory depression, which is why it's used a lot for procedural purposes, because you do get the sedation without the relatively moderate to high risk of respiratory depression. Okay. For paralysis, lots of drugs. All right, there's Sux, there's Vecuronium, there's Pabulon, there's now Rocuronium, there's Atracurium. All right. We tend not to use Sux anymore. I think it's an important drug for anybody who does what we do, okay, what you do. It's one of those agents that has a very long history. There may be people in the community that were trained, 15 to 25, years ago, who are very comfortable with that drug because they've used it their whole life. They're well versed with its problems. All right, so I do think it would behoove you to read a little bit about succinyl, about Sux, and know not, in what cases to avoid it. But again, because we have newer and better pharmacologic agents, that's kind of, in the same class with Valium and Demerol. It's just sort of fallen out of first-line therapy, okay? So I'm not going to spend a lot of time with it because it's a fascinating drug. There are a lot of problems, but since we don't use it, we'll talk about the other drugs that we do use, all right? But so there's your the short list, all right, of pain medications, sedatives, and paralytics. All right. So let's talk about how we choose between each drug or combinations thereof and why. Now, it is true that perhaps certain practitioners prefer certain drugs, all right? There could be many reasons for that. Maybe that particular drug that they like is superior, all right, to others in their class. Maybe it's because that practitioner that's the drug they have the most experience with. So even though it may not be the perfect drug for their job in their hands, all right, they can make adjustments and they can anticipate issues and tailor the dose and the interval, things like that, so that it actually works quite well. All right?